শুরু করছি। Good evening, everyone. On behalf of Heartline's Voices of Cardiac Anesthesiologists, I warmly welcome all of our seniors, our colleagues, and our students to today's session. After an enriching discussion on TAPPC, we are delighted to continue our pediatric cardiac anesthesia mini-series with our episode 2, that is a perioperative management of VSD, ventricular septal defects. Although the VSD is one of the most common congenital heart disease, but its perioperative management demands a thorough understanding of its physiology, pulmonary vascular dynamics, associated anomalies, and a careful anesthesia planning. From a small restrictive defects to a large shunt lesions with a pulmonary hypertension, each of our patients presents with unique challenges that requires thoughtful decision making. So we are privileged to have Dr. Soumitra Mukherjee with us today. Dr. Mukherjee will share his experience and practical approach to the perioperative management of VSD, with a highlighting the evidence-based strategies, common pitfalls, and the valuable clinical insights that will benefit all of us in our daily practice. So we sincerely thank Dr. Mukherjee for taking his valuable time to share his expertise with Heartline's family. So I request uh, every one of you, including the students and the seniors and colleagues also, to actively participate and to post your questions in our chat box so that we can make this kind of academic discussion most useful to all of us. With that, it is my great pleasure to invite Dr. Soumitra Mukherjee to begin today's session. Thank you. Over to you, Soumitra.
Thank you, Monisari. Let me share the screen first. Is my screen visible? My presentation is visible or not?
Yes, you are visible and audible too.
Okay, thank you. Thank you. So without much delay, let's start. Today's topic of discussion is that perioperative management of ventricular septal defect. Now, ventricular septal defect is very important, particularly for the students, both for theory as well as for the practical exam, because in practical exam, either a long case or a short case, VSD is a mandatory case. Almost every student will have to face the VSD as a long or short case. So, about the anesthesia management, particularly per se, is not very much different. But apart from the anesthesia management, the other perspectives of VSD, starting from embryology to pathophysiologic investigation and the echo findings, VSD is very important. So what is VSD? A ventricular septal defect is an opening in the interventricular septum resulting in direct communication between the left and right ventricles. It can be single or multiple, and it is the most commonly diagnosed congenital heart anomaly. VSD can be presented in an isolated lesion or in combination of other lesions. So VSD could be either a isolated lesion or associated any other lesion like if TGA or the truncus arteriosus, etc. Here I will discuss only the VSD as an isolated lesion. To start with embryology, the interventricular septum consists of three parts that develop from different sources, and they are muscular part, bulbar part, and membranous part. Now, these muscular, bulbar, and membranous parts come together and they form an uniform single interventricular septum. So although they are developing from three different regions, ultimately they coalesce and form a single septum between two ventricles. So when it is developing or when they are fusing with each other, there could be defect in between, and that ultimately leads to ventricular septal defect. So what about the muscular part? When there is nothing within two ventricular cavities, it is known as the bulboventricular cavity. It's a single large cavity. A septum called the interventricular septum grows upward from the floor of that bulboventricular cavity, and it eventually divides the lower dilated part of this cavity into right and left halves. Now, this muscular part of interventricular septum, when it is growing upwards, ultimately meets with the fused AV cushion or septum intermedium, and it partially fuses with them. About the development of AV cushion, I have already discussed in the previous class. So the muscular part grow upwards to meet and fuse with the AV cushion. Now, what is the role of bulbar part? Two ridges, termed the right and left bulbar ridges, arise in the wall of the bulboventricular cavity, and these ridges grow toward each other and fuse to form a bulbar septum. The bulbar septum, the behavior of the bulbar septum is just reverse to the muscular septum. Bulbar septum goes downwards towards the muscular part. So muscular part is growing towards upwards, and the bulbar septum is growing downwards towards that muscular septum of the interventricular septum, but does not quite reach it, with the resulting gap in between this bulbar part and the muscular part. Now, what is the importance of membranous part? The gap between the upper edge of the interventricular septum, that is the muscular part, and the lower edge of the bulbar part is being filled up by the proliferation of tissue from the right side of the AV cushion and the right and the left bulbar ridges. This is nothing but the membranous part. So actually the membranous part ultimately fills up the gap between the bulbar part and the muscular part. The membranous part of the interventricular septum is divisible again into an anterior part, which separates the right and left ventricle, and the posterior part, which separates the left ventricle from the right atrium. This anatomical specification is important because later on I will discuss a specific defect, the Jarbot defect. This Jarbot defect is actually happens congenitally because of problem within the membranous part, which is actually forming the posterior part. Coming to this picture, there are different sections, the coronal section and the sagittal section, showing the muscular part of the interventricular septum, that is the blue portion. The brown portion is the bulbar septum, and they are growing towards each other. Ultimately, they'll meeting with each other with the help of the membranous part. So, coming to the classification, ventricular septal defect can be classified in various ways. The most common approach for the classification is the anatomical classification. First one is the perimembranous VSD or infracrystal VSD or subaortic VSD. It is situated in the outflow tract of the left ventricle, immediately beneath the aortic valve. That is why it is also called as subaortic VSD. These type of defects involve the membranous septum, which might having the extension into the adjacent inlet, outlet, or the muscular septum. The muscular part or the trabecular part, they are entirely bounded. Just a moment. The muscular or the trabecular part, they are entirely bounded by the muscular septum. Now, muscular VSD can be again reclassified into different types according to their location. An anterior or marginal muscular defect is anterior to the septal band. A central mid-muscular defect is posterior to the septal band. An apical defect are inferior to the moderator band, and the posterior defect are beneath the septal leaflet of the tricuspid valve. So here comes two very important anatomical landmark. Number one, septal band and the moderator band. Septal band and moderator band both are parts of right ventricle, which are the anatomical landmarks. Based upon them, based upon their location, muscular VSD can be reclassified into either anterior or central, apical, or the posterior. Now, if there is multiple muscular defect in different location, it is often referred to as Swiss cheese type of VSD. It is having another importance because it cannot be closed surgically. So PA bending is the treatment of choice in most of the Swiss cheese type of VSDs. This picture is showing the location of septal band and moderator band. You can see that I have highlighted both the position of the septal band and the moderator band. The septal band, above the septal band, as I have mentioned, the location of the anterior muscular VSD. The central muscular VSD is posterior to the septal band. The apical defect are inferior to the moderator band. So these are the locations of septal band and the moderator band, accordingly location of different types of muscular VSD. The third one is the subarterial or the outlet VSD, which is also known as supracrystal or subpulmonary VSD. They are situated just beneath the pulmonary valve, that is also known as subpulmonary. Somebody called it as subarterial, and it communicates with the right ventricular outflow tract above the supraventricular crest. This defect frequently leads to prolapse of the right coronary cusp, or less likely the non-coronary cusp of the aortic valve, ultimately leading to aortic regurgitation. The last one is the inlet VSD. They are located posteriorly and inferiorly to the membranous septum. So it is very close to the membranous part of the interventricular septum. So according to anatomy, 4 types of ventricular septal defects are perimembranous VSD or subaortic VSD, muscular VSD or the trabecular VSD, subarterial VSD or outlet VSD or subpulmonary VSD, and the inlet VSD. Coming to this picture, the type A is the supracrystal VSD. Type B is the perimembranous VSD. Type C is the location of the inlet VSD, and type D is the location of the muscular VSD. Looking at this picture, this color picture, which is more easy to understand the locations of different types of VSDs. Look at the position of the type 1, that is the subarterial or subpulmonary, just beneath the pulmonary valve, just beneath the location of the pulmonary artery. Type 2, that is the perimembranous VSD. Then type 3, it is the inlet VSD, just below the location of the or placement of the tricuspid valve. It is the inlet portion of the left ventricle. Then it is the muscular VSD within the muscular interventricular septum. Now, classification based on the size and the hemodynamics. It is of three types: small, moderate, or large. Small or restrictive VSD. The small VSD is defined on the basis of the comparison to the size of the aortic root. If the size of the VSD is less than 1/3 of the size of the aortic root, or the total orificial area is less than 0.5 centimeter square per meter square, it is considered as small VSD. It is also known as restrictive VSD. Why? As the size of the defect is very small, so there will be limited flow from the left ventricle to the right ventricle. So that's why it is called as restrictive VSD. And then as the flow from the left to the right ventricle is limited, there will be excess generation of the pressure difference between the left and the right ventricles. So obviously the trans VSD gradient between the left ventricle and the right ventricle is more. It is more than 64 millimeter of mercury, quite high. That's why it is also known as restrictive VSD. As the total blood flow from the left to the right side is limited, so the pulmonary artery pressure never rises than the baseline value. So there will be always normal PA pressure. The pulmonary or aortic systolic pressure ratio will definitely be less because of lesser blood flow to the pulmonary circulation, and the value is commonly less than 0.3 with a very small shunt. That is, the QP/QS ratio is mostly less than 1.4:1. Eventually, the degree of LV volume overload is minimal, and there is less tendency or no tendency to develop increased PVR, but they can develop aortic regurgitation or bacterial endocarditis in future. What about the moderate defect? VSD size is said to be moderately restrictive when the size of the VSD is 1/3 to 2/3 of the aortic root, or the total orificial area is more than 0.5 but less than 1 centimeter square per meter square. The pulmonary aortic systolic pressure ratio is more than 0.3 but less than 0.66 with a moderate level of shunt, that is more than 1.4 but less than 2.2. Here the peak systolic pressure is more than 20 millimeter mercury between the two ventricles, that is less than 64, like in the small VSD. They develop moderate left to right shunt leading to volume overload of the left side cardiac chamber, causing moderate develop left ventricle or the left atrium dilatation and hypertrophy. The RV is not dilated, and RV and pulmonary artery pressure may remain low or be moderately elevated in the later age. The PVR is low, but it is variable and rarely progress to pulmonary hypertension. What about the large or non-restrictive VSD? When the VSD is very large, there is no restriction of blood flow from the left to right side, and when it measures more than 2/3 of the size of the aortic root, or the orificial area more than equals to 1 centimeter square per meter square. It is also known as non-restrictive VSD, as there is no resistance of flow across the defect. The degree of defect, the degree of left-right shunt is dependent on the relationship between the pulmonary and systemic vascular resistance. Means when the PVR is low, there is excessive flow from left to right, and when the PVR increases, rise of PA pressure, eventually the reversal of shunt develops. The pulmonary aortic systolic pressure ratio is more than 0.66 with the QP/QS ratio more than 2.2:1. The fourth one is the Eisenmenger VSD. A large VSD, if it is left untreated, can eventually result in irreversible damage to the pulmonary arterial tree with development of pulmonary vascular obstructive disease, that is PVOD, and Eisenmenger syndrome. The systolic pressure ratio is 1 and the QP/QS ratio is less than 1:1 with a net right to left shunt. There is almost identical right ventricular and left ventricular systolic pressure, and mostly suprasystemic PVR. What is doubly committed subarterial VSD? These are the defects considered as doubly committed subarterial VSD when little or no muscle is interposed between the outflow components of both the left and right ventricle, and when there is absence of the septal component of the subpulmonary infundibulum. So both the aortic and the pulmonary leaflet are directly related in fibrous continuity, and they are directly related to the VSD. The doubly committed subarterial defect lie immediately beneath both the valve of the aortic and the pulmonary valves. So the left and right coronary cusp of the aortic valve tend to prolapse easily into the outflow tract of the right ventricle, causing aortic regurgitation. This is the picture of doubly committed subarterial VSD. You can see that the placement of the VSD in such a fashion, in such a way that it is communicating both towards the pulmonary artery as well as towards the aorta. What is malaligned VSD? We commonly heard about the malaligned VSD in case of tetralogy of Fallot. So what is malaligned VSD? Malaligned VSD is categorized depending upon the position of the conal septum or the outlet septum. Most frequently, the outlet septum or the conal septum is malaligned in relation to the rest of the ventricular septum. I've already mentioned that the muscular septum, about the muscular septum, about the membranous septum, the bulbar septum. So all these things ultimately meet with each other in a regular fashion, and that if there is no malalignment, so there will be complete seamless formation of the interventricular septum. But in any case, if there is a breach or malalignment between the downward movement of the bulbar septum and the upward movement of the muscular septum, there will be malalignment. Now, malalignment could be of two types, either posterior malalignment or anterior malalignment. The posterior malalignment of the conal septum will result in protrusion of the conal septum into the left ventricular outflow tract, resulting in varying degrees of subaortic narrowing and the obstruction. This type of defect is often associated with aortic arch hyperplasia or coarctation or interruption of aorta. So posterior malalignment means hindrance of flow within the LV outflow tract. Just pardon me, my patient is a little problem. I'm just coming. Sorry for the inconvenience. Am I audible?
Yes, you are audible.
Okay. So, malalignment of the VSD is of two types: posterior and anterior. Posterior malalignment causes mostly the LVOT obstruction. What about the anterior malalignment? Here, it often results in the overriding of the aorta, and with varying degrees of subpulmonary and pulmonary valve narrowing and obstruction due to the coronal septum protruding into the RVOT. Commonly, we face the anterior malalignment in case of pathology of thyroid. What about the pathophysiology? The most important variables that determine the hemodynamics in a patient with VSD are the size of the VSD, I've already mentioned, small size, lesser shunting from the left to right, large size, more shunting from the left to right. Pulmonary vascular resistance, that is low PVR in case of small VSD, moderate, low to moderate PVR rise in moderate VSD, high PVR rise in case of large VSD, and the PVR SBR ratio, and the presence of associated defect like ASD, PDA, or right and left ventricular outflow tract obstruction and arch obstruction. So these are the factors which govern the ultimate hemodynamics of the patient with VSD. The pathophysiologic effect of VSD is actually secondary to the left-right shunt and changes in the pulmonary vasculature. So in the initial stage, even in large VSD, there will be left-to-right shunt and gradually increase in PVR and the PA pressure. Eventually, when the PVR is so high or suprasystemic than the SBR, there will be reversal of shunt and there will be right-left shunt. Left to right shunt at the ventricular level has three hemodynamic consequences. Number one, increased LV volume load, that is the LV volume overload, excessive pulmonary blood flow, as I already mentioned, and this excessive pulmonary blood flow happens in expense of reduced systemic cardiac output. The ventricular level shunts occur primarily during ventricular systole. The atrial level shunt, that is in ASD, the shunt occurs primarily during ventricular diastole, and both during systole and diastole, the shunt occurs in case of arterial level shunt, that is the AP window or the PDA. What will you found in clinical examination? The significant ones are: number one, the infants with large shunt, that is large VSD, will present with congestive heart failure, will be having malnourishment with poor growth and development. In patients with severe pulmonary hypertension, there is a left parasternal heave with a palpable P2 in the left second intercostal space. In non-restrictive defect with large left-right shunt and congestive heart failure, there may be a low volume pulse. On auscultation, what would you find? Number one, harsh long systolic crescendo decrescendo murmur, based heart along the lower left sternal border. The systolic murmurs in case of outlet defect are heard best in the second intercostal space. When the shunt is large, that is QPQ ratio more than 2:1, a short mid-diastolic murmur is heard at the apex due to the increased flow across the mitral valve. What about the characteristic feature of ECG? In large non-restrictive VSD, there is evidence of combined ventricular hypertrophy, that is biventricular hypertrophy. This is seen in mid-precordial leads as large equiphasic RS complexes, which is also known as Katz-Wachtel phenomenon. As you can see in this picture, that is in the V2 and V3 and then V4 also, there is equiphasic RS complexes. What about the chest X-ray? The chest X-ray findings are in case of large VSD, generalized cardiac enlargement with increased pulmonary vascular markings. There is prominence in the main pulmonary artery with RV enlargement. The findings of transthoracic echocardiography. The one best view is the parasternal short axis or donut view. And if we consider in accordance with a clock, the position of the different types of VSDs are outlet septum will be located in 1 o'clock position. The perimembranous defect will be located at 10 to 11 o'clock. The mid-muscular VSD will be located at between 9 to 12 o'clock, and the inlet defect will be located between 7 to 9 o'clock. What about the T findings? For the perimembranous VSD, the commonly used views are mediasophageal fourth chamber view, RV infraauricular view, and the aortic valve long axis view. Among them, I generally prefer the RV infraauricular view. In this view, the perimembranous VSD will be located in between 7 and 10 o'clock. And you can see in this picture, the asterisk and the arrow is locating the location of the pointing towards the location of the perimembranous VSD. What about the inlet VSD? The best view for the inlet VSD is mediasophageal fourth chamber view. For outlet VSD, the mediasophageal aortic valve long axis view, and again the RV infraauricular view. In RV infraauricular view, the defect is seen between 3 to 6 o'clock. So in mediasophageal aortic valve long axis view, if there is a confusion between perimembranous VSD and the outlet VSD, go to the RV infraauricular view. In RV infraauricular view, if the defect is located between 3 to 6 o'clock, undoubtedly it is outlet VSD. And if it is located between 7 to 10 o'clock, undoubtedly it is perimembranous VSD. What about the muscular VSD? For muscular VSD, the commonly used views are mediasophageal fourth chamber view, transgastric basal short axis view, and transgastric mid-papillary short axis view. Now, in certain situation, there is a possibility of spontaneous closure of the ventricular septal defect. The incidence of spontaneous closure is common in case of muscular VSD and perimembranous VSD, but it is low in outlet defect and almost impossible in case of inlet VSD. Swiss cheese muscular VSDs, they do not, although it is muscular VSD, but they do not close spontaneously. Now, most defects which close do so in the first year of the life, and approximately 60% close before the 3 years, and 90% by 8 years of age. Now, what are the causes of spontaneous closure of the ventricular septal defect? Number one, the adherence of the septal leaflet of the tricuspid valve to the interventricular septum, causing an aneurysm-like pouch. This can either partially or completely close the defect, but at the expense of causing tricuspid regurgitation. Number two, the ingrowth of fibrous tissue with endocardial proliferation, again causing septal aneurysm. Number three, prolapse of the aortic cusp, especially the non-coronary or the right coronary cusp through the defect, can close the VSD, but at the cost of causing aortic regurgitation. For muscular VSD, growth and hypertrophy of the muscular portion of the septum around the defect cause spontaneous closure of the ventricular septal defect. Now, as I have mentioned, that aortic regurgitation could be associated with ventricular septal defect. The cause of the aortic cusp prolapse and the aortic regurgitation in the doubly committed subarterial VSD is due to the anatomical unsupported right coronary cusp with the combined venturi effect produced by the VSD jet. And in case of perimembranous defect, the AR is more due to the collapse of the non-coronary cast. So there are two reasons for aortic regurgitation. I mean, two mechanisms. For perimembranous defect, it is commonly collapse of the non-coronary cast, and for subarterial or subpulmonary VSD, the cause of the collapse is the right coronary cast. Now, why there is venturi effect? The magnitude or the direction of the flow is from the left to the right ventricle. Now, when the flow is from the left to right ventricle, gradually it is causing a venturi effect within the right ventricle, and it is pulling the unsupported, anatomically unsupported coronary cast. Either it is right or it is non-coronary cast according to the location of the VSD. For subarterial, it is the right coronary cast, and for perimembranous, it is the non-coronary cast, ultimately leading to aortic regurgitation. So, two reasons. Number one, prolapse, unsupported, prolapse of the unsupported aortic cast, and number two, venturi effect. What is Jarbot defect? It is a rare type of VSD communicating the left ventricle to the right atrium. I've already mentioned the defect within the membranous part of the interventricular septum causing the Jarbot defect. The Jarbot defect results from a defect in the membranous septum. It could be either congenital or acquired. Congenital, as I have already mentioned, defect within the membranous part. The acquired one is seen following ventricular septal perforation in the setting of bacterial endocarditis, trauma, post-myocardial infarction, valve replacement surgery, and following surgical closure of the VSD. Now, this Jarbot defect could be of three types. Number one, supravalvular defect. The shunt in supravalvular Jarbot defect occurs between the left ventricle and right atrium above the septal leaflet of the tricuspid valve, and here the tricuspid valve remains intact. It is also known as direct type or type 1. The infravalvular or indirect or type 2 Jarbot defect, the shunt produces a communication between the two ventricles, and then the shunted blood enters the right atrium through the right ventricle. So left ventricle, right ventricle, then to the right atrium through the associated defect in the tricuspid valve. So in supravalvular, the tricuspid valve remains intact. That is why it is called as direct type of Jarbot defect. But in infravalvular or indirect type, the tricuspid valve is defective. It is not intact. That's why the direction of flow from the left ventricle to right ventricle to right atrium. And the third one is the combined supravalvular and infravalvular defect. What are the indications of cardiac catheterization in case of ventricular septal defect? Normally or generally, cardiac cath is not required in case of VSD. Transthoracic echocardiography is enough to get the idea of the anatomical details for VSD. In some situation, we do require cardiac cath. Number one, if there is uncertainty regarding the either defect number or size or location and hemodynamic burden, or we are suspecting the presence of some additional lesion. The anatomy of multiple apical VSD is delineated on angiogram. Even those defects which cannot be delineated or identified accurately by MRI or by echocardiography, here the importance of cardiac cath is there. Second indication is when we are doing interventional device closure, and sometimes in case of older patients, we need to know about the PA pressure, the value of the PVR, and the reactivity, the reversibility of the elevated PVR. Accordingly, the surgical decision will be taken. The QPQS ratio can be estimated from the cardiac cath. The calculated QPQS ratio, if it is greater than 2:1, it is generally considered as an indication for intervention. That means the direction of shunt is still left to right. The PVR can be calculated in Wood's unit with the formula of mean PA pressure minus mean LA pressure divided by pulmonary blood flow. The mean PA pressure and the mean LA pressure can be directly estimated by the placement of the catheter in that particular location, and pulmonary blood flow can be calculated by the fixed principle. The PVR-SVR ratio, if it is less than 0.25, it is considered as operable, whereas the ratio more than 0.5 is usually beyond the operable range. Now, when we are doing a cardiac cath in case of perimembranous VSD, again it can be classified into 4 types based on the ventriculography. Type 1 is the tubular type, where the shunt jet is long and the diameter in the right and the left sides of the septum is the same. Number 2 is the window-like type. Here, the shunt jet is scattered immediately after crossing the septum. Number 3 is the aneurysmal type. Here, the shunt jet has an aneurysmal shape. And the conical type, the 4th one, the shunt jet is wide enough on the left side of the septum and narrow on the right side. Coming to the guidelines of the European Society of Cardiology about the operability of the VSD, it is the guideline about the adult congenital heart disease, but it can be applied to the pediatric age group also. So, what is the class 1 indication? In patients with evidence of LV volume overload and no pH, no non-invasive signs of PA pressure elevation or invasive confirmation of PVR if it is estimated less than 3 wood unit. In case of such signs, that is signs of elevated PA pressure, VSD closure is recommended regardless of the symptoms. What are the class 2 recommendations? Number 1, in patients with no significant left-right shunt but history of repeated episodes of infective endocarditis, closure to be considered. Second indication, patients with VSD associated prolapse of an aortic valve cast causing progressive aortic regurgitation, surgery should be considered. Number 3 indication, third 2 indication, in patients who have developed pH with PVR between 3 to 5 wood units, VSD closure should be considered when there is still significant left-right shunt and the QPQS ratio more than 1.5. Class 2B recommendation is that in patients who have developed pH and the PVR now has risen more than 5 wood units, VSD closure may be considered when there is still significant left-right shunt. That means QPQS ratio more than 1.5. So, significant left-right shunt, QPQS ratio more than 1.5. If the PVR is more than 5 wood unit, recommendation is class 2B. But the same situation, same condition, if the PVR is between 3 to 5, the indication will be class 2A. So, whenever we are dealing with an older age group patient having VSD, we have to calculate all these values. That is the PVR, the magnitude of the left-right shunt, the QPQS ratio, all these parameters we have to calculate. What about the class 3 recommendation? VSD closure is not recommended in patients with Eisenmenger physiology and patients with severe PH, that is PVR more than 5 wood units with significant right-left shunt presenting with desaturation on exercise. What about the device closure? It is reasonable for infants who are weighing more than 5 kg, children and adolescents with hemodynamically significant left ventricular or left atrial volume overload, or pulmonary to systemic blood flow ratio more than 2:1, having either muscular VSD or perimembranous VSD, the percutaneous device closure can be done. Amplifier device is most commonly used. These are the pictures of different types of VSD device. This video is showing how it looks in the cath lab when the VSD is closed with the device. So this is how the VSD is closed in cardiac cath lab. What about the anesthetic consideration? The anesthetic, I will discuss only the significant ones. If the patient is having large VSD with significant left-right shunt and patient is presenting with congestive cardiac failure, so preoperative optimization, primarily with the diuretic therapy, is to be done definitely for proper optimization. Then only we can go for the surgery. Management of pulmonary hypertension, there are lots of pulmonary drugs which can be prescribed in the preoperative period to counteract the component of the pH. So there is less possibility of perioperative PA crisis. So it is better to control the raised PA pressure in the preoperative period, and definitely to continue the same therapy or add-on therapy to manage in the perioperative period. In the perioperative period, there are possibilities of conduction disturbances because the conduction system, they are very close to the location of the VSD, particularly the perimembranous one. So there will be possibility of atrioventricular block. There in AV block, the AV sequential pacing is desired. There are sometimes episodes of junction tachycardia, which can be managed according to the guidelines, that is either amiodarone or depending on anesthesia, and sometimes cooling of the child, etc. So intraoperative T, it is having a very, very high importance because adequacy of repair to be seen thoroughly, whether there is any patch dehiscence or patch leak, or there is any residual VSD is present or not. So during the postoperative T, if indeed a residual shunt is found, it should be interrogated definitely to assess the pressure difference between the ventricles as an indication of pulmonary artery pressure. And definitely when we are calculating the gradient across the residual VSD or across the shunt, we can calculate the mean pressure and the maximum pressure across the two ventricles, that is the left and right ventricle. And from, if we get the pressure, the estimated pressure of the right ventricular systolic pressure, we can have the idea of the PA pressure, provided there is absence of alveolar obstruction. Apart from the location or apart from looking at the residual VSD, what are the other parameters we have to look into it? Number one, the aortic, the atrioventricular valve function should be assessed, especially if there was manipulation of the atrioventricular valve, particularly the tricuspid valve during the surgery. Semilunar valve function, particularly the aortic valve, should be carefully evaluated for any leaflet prolapse or regurgitation, even if it was normal in the preoperative period. Potential difficulty arises when a residual shunt is identified and deciding whether or not it is hemodynamically significant enough to readdress it. As this means reinstitution of the CP bypass to revise the repair. Important data that can assist surgical decision making include the number and the size of the residual VSD. A residual VSD color jet diameter in color flow Doppler study measured in T if the size is more than 4 millimeter, there is need for reinstitution of the septal bypass, and we have to correct it. If the residual defect is less than 3 millimeter, generally these are not hemodynamically significant, and we can left it hoping that it will be closed spontaneously. But there are certain situations, certain equivocal situation, there we have to calculate the QPQS ratio. The formula of the QPQS ratio is difference between SaO2 minus SbO2 divided by pulmonary venous saturation minus pulmonary saturation. Now, we have to collect 3 samples from the central vein, from the pulmonary artery, which will be done by the surgeon, and the saturation which will got from the ABG. Conventionally, we assume that the saturation of the pulmonary vein is 99 or 100%. So based upon these 4 values, we are having the value of QPQS ratio. If the QPQS ratio value exceeds more than 1.5, it is recommended to return to CP bypass again and to close the residual shunt surgically. If the value is less than 1.5, we can lift it upon, assuming that it will be closed spontaneously. Thank you. That's it.
Thank you so much, Soumitra. Any questions or any comment? আচ্ছা, পরের দিন কি পড়াবে?
পরের দিন পড়াবো হচ্ছে আমি TAPVC, টোটাল অ্যানোমিনাস
হয়ে গেছে? হ্যাঁ হ্যাঁ
হয়ে গেছে না? আচ্ছা, তাই পরের দিন পড়াবো হচ্ছে আমি পরের দিন কি পড়াই বলো তো? তাহলে আমরা কাজ করি, না টিএপিসি হয়নি তো, আমরা এবি সেপ্টাল ডিফেক্ট পড়িয়েছি।
হ্যাঁ, টিএপিভিসি হয়নি, এক্স্যাক্টলি টিএপিভিসি হয়নি।
টিএপিসি পড়া যাবে।
আচ্ছা, তো ওই কোয়েশ্চেন আনসারের কথাটা আমরা একটু বলে দিই। সো as our discussion, we wants to be interactive one, so we'll be providing 5 to 10 sets of MCQs based on our classes to all of you, especially our youngsters, our students, so that they can read the topics, and they will answer the questions as possible. Who is going to answer these questions first and accurately, there is prize money for the students or them, one or more students. So we encourage all of you to participate in that kind of quiz session, so that it is beneficial for you also, because you go through the topic and the books we have provided, the name of the books that you should read for each of the pediatric cardiac anesthesia session for all the diseases and all the physiologies, and you will be having a very strong physiological background with this kind of textbooks. And any other suggestion?
See,
for the
in pediatric cases, if it is a long case, they will start with anatomy, physiology, embryology, all these things, investigation. If you are answering very well, then only they will enter into the anesthesia management part. So for pediatric cases, the person who are appearing for pediatric cardiology exam, you have to know at par or at the same level of them about the pediatric physiology, the pathophysiology, the examination findings, the investigation, the anatomy, embryology, everything. Okay, and even for practice purposes, I mean, in practical scenario, in day-to-day practice, apart from the anesthesia knowledge, particularly for complex congenital heart disease, being a pediatric cardiac anesthetist, you have to know thoroughly about the anatomy and the pathophysiology. It is difficult to understand the pathophysiology, particularly how to manage the QPQS ratio in congenital complex lesion. It is different from the adult one because the variety of adult cases are less, CABG and valve cases. But for pediatric, management of TGA is completely different than the management of TAPVC. TAPVC management is completely different from truncus arteriosus. So, pathophysiology and anatomy of every single congenital heart lesion you have to be mastered. Otherwise, you cannot manage those cases confidently. Cannot.
Thank
It
you.
is my opinion, actually.
Definitely, it's absolutely true. Absolutely true. So you have to be master of every single pediatric cardiac diseases and clearly about the physiology.
Yes.
So thank you so much, Soumitra, for such an excellent and practical session on the perioperative management of VSD. And thank you all of our senior colleagues and our students for active participations. So we hope to see you again on next Saturday at 7 p.m. for a class on TAPVC and in our next Heartline session. So have a wonderful evening. Thank you so much.
Monalisa ji, somebody has one question in the chat box. Dr.
Okay.
Preeti Raj. Dr.
Yes.
Preeti, are you there? Okay. So the mode of anesthesia in pediatric age group, I use during the intraoperative period the fentanyl, and in the postoperative period also the fentanyl infusion. And the apart from that fentanyl infusion, I also use paracetamol. That actually suffices the analgesia. The regional technique or the different types of block, I usually do not use in the pediatric age group.